Today we are embarking on a second monitoring and evaluation echo session, and these are series. As we mentioned in the first series, we started with Tanzania, the experiences revolving around programming and utilization, use of dashboard to optimize performance. And they did present to us on how they're using a dashboard and improving performance. And this series, they're supposed to be 4 in a year, and this is the second one. And today, we're going to share with you on utilizing results from the perspective of a results framework. We know that results framework is important as a tool that everyone involves and is engaged through, because it defines a number of parameters that includes the objectives of the program, but also defines the indicators, but also defines the data sources. And in this case, we are going to present to you how Uganda has used, the Ministry of Health have used the results framework to track their performance towards reaching the triple 95, 95, and 95, which all of us, we are aware that by 2030, we should be able to reach that milestones. In that case, how are they identifying their strength based on the results framework, which has the objectives, but also has the indicators, also has the targets, and also define the frequencies. But also, how are they identifying the gaps using the results framework? Do we have evidence that will show and demonstrate that the results framework is able to mobilize and also coordinate all the players in the country, but also showcase some of the changes that comes as a result of focusing on the goal? Do not miss the goal. We can spend a lot of time doing activities from one workshop to another, forgetting that it's the goal, it's the framework that we agreed at first in terms of reducing HIV and its impact. So today I'll present to you Patrick Agba from the Ministry of Health, who is the Director of Quality and Standards in the National Health Laboratories and Diagnostic Services, but also Madam Claire Nankoma, who is also the Monitoring and Evaluation Officer in the Ministry of Health, working together with Patrick. But we also have a team that are going to support them in case there are issues or questions. So I would like to invite Madam Claire to start the presentation and share their experiences of using the results framework. Thank you. Over to you, Madam Claire.
Good afternoon, good morning from wherever you're listening in. Maybe before I make my presentation, I'll invite Patrick to do an introduction, and then I can get into the presentation. Over to you, Patrick.
Thank you very much, Claire. Good morning, good afternoon, ladies and gentlemen, and thank you for attending this echo session for today. My name is Patrick Ogwok. I'm responsible for laboratory quality assurance in Uganda, and we are going to give you a bit of our experience, of course, starting from the time when HIV was introduced. You remember that HIV, when it came, it was actually Uganda and Thailand that came up to say, yes, we have some virus here. I think it's a problem. So that's when things started coming up. So Claire is my colleague. We are going to co-present with her, and of course she will be the main presenter since she's the M&E expert. And we also have Dr. Victor Bigira, who is an M&E expert as well. Of course, we are in the Department of National Health Laboratory and Diagnostic Services of the ministry. But then since we are looking at the impact, we shall go more to the impact side. So you will find that the lab, we shall talk about it less, but mainly the outcome and impact side, so that you look at what we've done generally as a country. So thank you very much again. We shall, of course, be asking you if you have any questions, please share it in the chat and we should be able to answer the question. So Claire, please take over on the presentation side.
Beautiful. Yes. Again, Claire Nankoma is my name. I do monitoring and evaluation at the Department of Lab under the Ministry of Health in Uganda. And today we are really explaining and just sharing our experience, improving results utilization towards the UNAIDS 95-95 using the results framework. And this is the Uganda experience. I don't know how many have visited Uganda, but where the arrow is where Uganda is. We fall in the Eastern Africa, bordered by Kenya, Tanzania, Congo, and South Sudan. So if you're looking for us, that's where we lie. We have a population of about 42 million Ugandans. And our first case of HIV and AIDS was actually diagnosed in a South district in Rakai at the shores of Lake Victoria, which is between Uganda. And this lake is shared between the three countries. Between 1987 and 88, we put the average prevalence at about 9%. That is of the adult population. Currently, as of December 2023, our burden, we started with 1 million. Now we have 1.4 people living with HIV and AIDS in Uganda. So that is our burden as we stand in Uganda. Briefly, if I should take you through where it all started, of course, like I said, it was first diagnosed in 1982. That's when it was declared. And between 1982 and 86, people were actually trying to understand, what is this? At first, the response was confined to the health sector. It was actually looked at as a problem for the health system. And so it was handled like any other epidemic. Although a small population in the region where it was first found thought it was witchcraft. And of course, with witchcraft, they were using local mechanisms of dealing with it. And then later they understood, because of the transmission mechanism, it was branded as a disease of the immoral, which of course led to very high levels of stigma among the people that were living with HIV. And of course, at that time, it was not something someone would be proud about if they knew you had HIV. And at that time in the country, the most significant characteristic of someone who was living with HIV was the very big weight loss, which is slimming. And so locally, they called it slim. Like, it was obvious, you are fat and you get small, you have the slimming disease. So it had a lot of stigma. However, in 1986, the health minister then announced the existence of HIV/AIDS during a World Health Assembly in Geneva. So at that point, it became a point of concern, and that is when the first AIDS control program was established in Uganda. 1987, it was now recognized that AIDS was not only a public health problem, but also a social and economic disaster. So affecting not only the health, but also affecting your social life, affecting the economics, because people were unable to work, people were not being able to maintain their responsibilities like family heads, of course, as mothers. So it became a multi-sectoral approach during 1987. In 1992, the country formulated and adopted the National AIDS Policy, and the Uganda AIDS Commission was legally established under the Office of the President. Now, the AIDS Commission was legally given the mandate to oversee all HIV programs. And of course, it still runs the mandate in the country. Now, USC becomes a managerial or the overseeing body. And then in terms of implementing what the commission was looking at, 1994, the AIDS control program units were established and these were spread across all the ministries. Remember, we started from Ministry of Health, and now it started spreading from Ministry of Health, Ministry of Finance, Ministry of Gender. All the ministries were now brought on board to take care of the disaster that we are facing. Now we see advances from 1997 to date. Over 1,200 agencies are implementing HIV-related activities, and these are coordinated through what we call 3 ones. One, we have one National AIDS Coordinating Authority, one Agreed AIDS Action Plan, and one country-level monitoring and evaluation system. So from that time to date, that is what has shaped our national response to date for us to achieve what I am about to share with you. So in terms of the monitoring and evaluation approach, the goal is the SDG 3, which is ensuring healthy lives and promote well-being for all at all ages. The objective, end the epidemic by 2030. Where are we? 2025. I don't know whether we're close, but yeah, it still remains our objective to end it by 2030. The NDP goal 4, enhance the productivity and social well-being of the population. Now, our national strategic plan goal becomes now increasing the productivity, inclusiveness, and well-being of the population through ending AIDS by 2030. Now, Uganda as a country aligns its goal with the goal that we are seeing right from the SDG. Now, from that one, of course, we develop the objectives and expected outcomes. The objectives spread across by reducing infections among the pediatric, and by 2025, reduced HIV-related morbidity and mortality, and contribute to preventing the new HIV infections by 2025, strengthen social and economic protection to reduce vulnerability to HIV and AIDS and mitigation of its impact, improve multi-sectoral HIV and AIDS service delivery system that ensures sustainable services to all targeted populations. And then the last objective is to strengthen the national HIV and AIDS strategic information management system for improved effectiveness and efficiency. And I think that is where this ECHO is looking at. How are we using the information that we have, or the things that we've put in place, to make sure that this is in place? And all these ones can be found in our national HIV and AIDS strategic plan that is running and is ending 2025. So from the objectives, now we break it down to the outcomes and the impacts. Of course, having the objectives up there is very nice, but we need to bring it down to a level of how can we accurately be sure that we are achieving these goals. 95 is really high up there, but in the day-to-day work, people must be bringing in things on board that at the end of the day will contribute to the 95. The first impact is coverage and utilization of biomedical HIV prevention intervention delivered as part of integrated healthcare. And I want to draw attention to 2.3, the indicator 2.3, which is looking at percentage of women and men aged between 15 and 49 years of age who tested HIV positive in the last 12 months and know their status. We all know that that is our first 95. Of course, breaking it down there, we also look at key and priority populations who have received an HIV AIDS test in the last 12 months and also know their status. Now, it breaks it down from just the general population, but also some priority populations who for some reason might actually be missed out, basically because of the society, the environment, whatever activities they're involved in. So the country puts an indicator that will go an extra mile to look for people like the long distance truck drivers, fisher folks, transgender people, people who use drugs. We want to go an extra mile, not to lump them up in the general population, but look out for those special populations. Of course, by the time this was developed, we were still at 90% the target. That's why you're seeing that target. But we are now measuring against the 95 target. Still looking at the other indicators, now moving down to the second 95, we are looking at reduced HIV-related morbidity and mortality and contribute to preventing new HIV infections. How do we do this? It means that whoever is diagnosed with HIV, we must link them to ART. And so now we put indicators there to look for, like 1.1, proportion of diagnosed HIV positive persons who start ART within 1 month. At the time, yes, but now we are implementing the test and treat. We do not want to defer treatment, or else this person will actually miss the opportunity of being on ART. And that is broken down through the different age categories and even gender: female, women, male, 0 to 14, adolescents, because each of those categories has different experiences and they have special ways to deal with them if we have to get them onto ART. Then, of course, once we get them on ART, we want to look at retention, how many we are actually retaining, because unless they remain on ART, then we cannot be sure that we are going to get them virally suppressed. The other indicator, as we move to the last 95, adherence on ART therapy increased to 95% by 2025. Proportion of active clients with an adherence that is greater than 95 in the last clinical visit. So we have cards that every time the client comes to the clinic, we actually assess for adherence, because we know that adherence is directly proportional to, in most cases, proportional to viral suppression. If someone is not adhering, the chances that they're not going to suppress are really high. Of course, the last number 4, viral suppression increased to 95%. What is the proportion of the people that we have put on ART? 4.1, proportion of people living with HIV who have a suppressed viral load. All adults, and then we break it down to each of the different categories, because then we will be able to know what interventions to put in place. If we just look at males, what is the challenge among males? If it is adolescents, what is their challenge? Why aren't they virally suppressed? Now, that is our results framework. And like I said, you can find it in our national strategic plan, well lined out. Of course, I picked bits and pieces that would relate to our 95-95. There is a lot more that you can find in the plan. How does data flow to inform? Because clients go to the health facilities, but the AIDS Commission is at the national level to monitor the implementation. So the National Strategic Plan, Monitoring and Evaluation Plan provides for us a framework for comprehensive data collection, aggregation, storage, reporting, and dissemination. So I just pulled out the outcomes, the indicators, but in there, they'll indicate who to report, how to report, where to report, and the frequency. At the client level, that is at the health facilities, we have what we call the pre-primary tools. We have the HIV test services card, and this is the initial card that the details of a person who is going to be tested interacts with. So that takes the details of the client, and then they get tested. Once they get tested and they turn out to be HIV positive, then they are enrolled into care, and then they'll get a different tool, which is the ART client card. The ART client card is the primary tool that the clinician or whoever is looking at this client interacts with and documents all the encounters with the HIV positive clients. For the babies who are mothers, we have a different tool, which we call the exposed infants chart. Now, those are for the babies who are born to HIV positive mothers. These tools these are from a client information with the healthcare provider. When information is entered on these tools, these are just cards. Then it is transcribed into a primary tool, which we call before you're enrolled into care, we have a register. Now, the client card is an individual card to an individual client. The registers, on the other hand, is a collection of multiple clients into one register. We have a pre-ART register. Those are clients that have not yet been enrolled onto ART for one reason or the other. But whoever has been enrolled on ART, we put them in an ART register. And it has been designed in a way that you have up to 72 encounters. So I enter the details once, and every time the client comes, I keep entering the information for this client. Then we have a laboratory register, which of course takes care of all the laboratory requirements if the client comes to the lab for testing for any tests. The early infant diagnosis register, it's the register that combines all the HIV exposed infants who have been now entered into the system. The HTS register is a summary, is a whole compilation of all the clients that we have tested. Like I said, pre-primary is an individual card to a client. Primary, a combination of all the clients put into one register. Now, that is at facility level. At the end of every month, now, data is aggregated to answer the indicators as stated. 105 is a monthly report that takes care of all the tests that have been done, how many have turned out positive, how many have been linked to care, all that. Then we have what the 106A, and that is a quarterly report. These ones are now aggregates of what the different health facilities in the country have been done. Whereas when I go to a health facility, I'll find a primary register. The register will have details of the clients in that health facility. When I come to the secondary tool, I have a summary of all the testing that has happened in the country for as long as someone has reported. For as long as a facility has reported, all their information will be found in the secondary tool. When this information is compiled at the district level, then it is submitted through the district health information system, DHIS2. And it is from the DHIS2 that we get the aggregated information broken down by region, by district, by health facility level. And that is where all the analysis that we want to do for the program come. Now, the National HIV and AIDS database at the AIDS Commission is linked to other ministry databases. Remember when I was speaking earlier in our journey, HIV and AIDS started as a health problem, only health problem, but now we appreciate that it is a multi-sectoral approach. So the database at USC is linked to other ministries. It's like the Office of the Prime Minister, EMS, the logistics, all those databases. And then USC uses this data to write our annual AIDS status report. And it is through this data that we do our annual joint AIDS review, and then quarterly reports, and then the country progress reports, and we submit them for program performance to the Office of the Prime Minister. Now, I must mention that the fight for HIV in this country is a priority to the first office, and it is directly under the Office of the Prime Minister. So we have to account for all the HIV-related activities. So once all these things are done, we have done our joint reviews and everything, our program performance report is submitted to the Office of the Prime Minister. These are some of the things that I just wanted to bring for you, our most recent fact sheet. And these will be summaries. They'll tell you like the prevalence significantly has improved from a 7.2 in 2010 to 5.1 as of 2023. We notice a decline in HIV new infections, 61% from 97,000 in 2010 and 38,000 in 2023. And of course, that would be attributed to various prevention and treatment programs. The other thing that we notice is a decline in the HIV and AIDS-related deaths. We had up to 53,000 in 2010, And in 2020, we are seeing a reduction to 20,000. This is attributable to the wider access to arts, and which was made available in 2001 when we rolled out free ART, and then the country's ability to cover all the treatment needs. This is a brief to show you that when the data is collected right from the grassroots, yes, the Commission and all the other stakeholders sit down and we analyze this information and find out where exactly the gap is. Where are we as far as the 95 cascade is? And this is based on the spectrum estimates. This we are standing, all ages, we are at 92% for the first 95, and 98% for the second 95, and 89 for the third 95. Looking at the different age bands, you will notice that the lowest performing age band is the 0 to 9 years, followed by let's say between 10 and 19, and then 0 to 14, basically the teenagers. Whereas the adults seem to be catching up on the 95, we still have challenges with those age groups. One, because we know many of these are school-going children, and so they are bound to miss service here and there because we have not integrated it within their school calendar. So we try to work around the school calendar. Partnership. Like I already alluded to this, the Uganda AIDS Commission is the coordinating body, coordinating arm for the national HIV and AIDS response. But we work together with a partnership committee, which meets quarterly and appraises the members on the National Strategic Plan implementation and resource mobilization. We have a partnership forum, which is a general assembly for all stakeholders, and this sits once every 2 years. Then we have a committee of technical experts, which plays a very key role in the policy and technical advisory to the USC. Of course, all the ministries and development agencies are part within their mainstream work plan. They have to have a column or a line for HIV. And these are mandated to mainstream HIV and AIDS activities into their policies and programs. Now, that is mandatory. So there is no saying that my ministry is different in their programs. There has to be HIV and AIDS mainstreaming. And of course, we work under the Ministry of Health AIDS Control Program, which is implementer of the National Strategic Plan. Now, how do we monitor? Of course, we monitor the reporting rates, and I wanted to mention, just pulled out this one. This is the last October, November, December, the HIV quarterly report. Those are things that we also monitor. It is not just about, but how are we submitting the HIV report? And of course, when we talk of the HIV report, it means it is the comprehensive report that has all the other indicators, looking at how many districts have reported, how many have given us complete data, and all the other reports. But I just wanted to tease out the HIV quarterly report. And by that time, at 97.8% reporting rates. Learning and adapting the strategic plan. It is one thing to plan, it is another to monitor, and it is another to actually utilize, find when you monitor. So we do joint AIDS review, and I wanted to just look at the most recent one, the joint AIDS review of 2024. It is a multi-pronged consultative and participatory process. What happens? In this particular review, we had a document review, and which documents were reviewed? Documents that were relating to activities that were planned for 2024. We had a presidential fast track initiative, global AIDS monitoring, modes of transmission, key population. A number of documents were reviewed. Why? Looking at what had been planned in those documents, what was expected to be achieved, which strategies had been put in those different documents. Then from there, a secondary data analysis was done. And this really looked at PEPFAR data and accountability transparency information, DATIM. I know most of the M&E people here know that system. That is where most of the reporting for HIV is done, looking at the hybrid and the dashboards for gender-based violence, early infant diagnosis, and HIV viral load. Secondary data analysis from those systems. Then from there were stakeholder consultations, civil society organizations, implementing partners, and the beneficiaries, the people who are living with HIV, the youth. So perspective of what we are evaluating. Or if I look at it from my own perspective as a programmer, will I get the true thing? So we get stakeholder consultations that were done with all those people to make sure that the evaluation was actually accurate and was not leaving anything unturned. And finally, there were meetings with the technical working groups. These meetings have value that was gathered from the document reviews and then served as a forum to review and draft the reports and then dialogue on future plans and targets. So in summary, that is how like 2024, but even the subsequent ones. In brief, that is what we do. Look at the documents, secondary data analysis, then stakeholder consultations with the technical working groups to validate the information that we have gathered. And then finally, the joint age review report that is submitted as a position of what has been done. I talked about the Presidential Fast Track Initiative. So when they were reviewing it, this is what it was. This is just a summary. What was and what was expected. So pillar 1, revitalize HIV prevention and close the tap on new infection, particularly. So in terms of prevention, what did they find? They found that 153 million condoms were distributed and they met the need of 62%. The initiative was to skill a girl and boy child rich with skilling hubs, because we know that once they're engaged, then maybe they'll have less opportunities to engage in risky sexual behaviors. School learners were rich with menstrual hygiene. If I go down to consolidating the progress on eliminating mother-to-child transmission, which was also one of the things that were in the presidential initiative, how many of the mothers were attending ANC and how many were actually being tested and how many received ART. So the progress by that time, 98% of the mothers were attending ANC and had an HIV test. 95% of the infected mothers received ART, with 92% of the mothers at first ANC being virally suppressed, which means that there is a higher chance of having babies born without HIV. If I go to this next pillar, which is accelerate implementation of test and treat. When you test, do not defer treatment. If the person is eligible and has been confirmed and they are willing, please start. Because when we defer, we could miss the opportunity. Overall, 92% knew their status, and of these, 90 of them were on ART, of which 94 were virally suppressed. And of course, that was measured across the different age groups. Addressing financing and sustainability for HIV response, HIV mainstreaming among the ministries and departments and agencies and local governments was strengthened. And by that time, 98% of the MDAs and 89% of the local governments had mainstreamed HIV-related activities, and up to 61 billion was mobilized through mainstreaming. The summary of challenges and gaps. This is during the joint age review when they were doing the reviewing of the documents. What did they find? Under HIV prevention, progress on preventing HIV infection is too slow to achieve the 2025 targets. I may not go, but you realize that while doing this, we actually break it down to make sure that we have tangible action points. Our target year is 2025. This is 2024. When they looked at the gaps, what was the action point? Accelerate HIV prevention efforts using the differentiated approaches for target population subgroups. No longer one size fits all, but look for approaches that are specific to the age groups. In terms of HIV care and treatment, inequalities in access and uptake. I already showed this. The children and adolescents and young people seem to be lagging behind in terms of ART coverage, viral load, and so identify innovative strategies to approach this particular population. And what does this amount to? So what? Now we have done it and we have found that. One, we do Uganda population HIV impact assessment. And this is done. The first one we did in 2016 and 2017 was basically to measure the status of Uganda's HIV response. And so through that, we offered HCT, basically making sure that, and that was addressing specifically the first 95. So what did they find? 77% knew their HIV status, scaled up assisted partner notification. Now, we discovered that during that time, some people were not able to disclose. And of course, that affects your adherence, your enrollment into care. So the approach at that point that was scaled up was assisted partner notification. What did it yield? It yielded 15% positivity, meaning that we had more people identified as HIV positive, meaning that we could even get them onto care. The second population impact survey was done between Feb 2020 and 21. This was actually assessing the progress too. Now, between 2020, March 2021 and December, specifically, we looked at the refugees. Among the adult population living in the refugee settlements to estimate the prevalence of HIV and the viral suppression. ART coverage increased due to introduction of the multi-month dispensing ARVs, more than 3 months to stable clients. So for a client who was found to be stable and has understood, that one would be given multi-month dosages. One, to reduce their transport costs, but also be able to allow them to enjoy their health. If they didn't need to see a clinician, they only need to take their pills, then that would be perfect for them. The ministry also scaled up community distribution of ART by establishing 118 community pharmacy drug distribution points, which improved access to ART, thus improving the second and the third 95. Out of the many gaps, we noticed the children and adolescents were like the ministry, or how does the country ensure closing of the gaps? One of our key strengths is using campaigns. Campaigns, this is a campaign that is currently running, locally known as Munonye. Munonye is a word, the language used in the central Luganda, which means seek, find. So it was branded Munonye, it is find the child. So over 12,000 unidentified children and adolescents were between 0 to 19 are living with HIV. What were the objectives of the campaign? Identify 80% of these children who are living with HIV, who have not yet been identified in the regions during October 2023 to September 2024. And then link 95% of these identified children to care and treatment, and then document lessons learned during the campaigns. This is an ongoing campaign, and I'd like to briefly give you some of the achievements. We aimed to identify 80% of estimated 12,000 of the undiagnosed children and adolescents living with HIV. What did we find in 12 months? We're able to identify 9,600. Not bad. Outcomes of the campaign, 6,652 were identified out of our target, which was 9,600. Were able to identify 6,000, about %. And then over 50% of the total undiagnosed were identified during the 2 quarters with a yield of 0.6. The campaign exceeded the set national targets. That means the HIV testing of 140, and then the positive target of 386. Additionally, nearly 70% of the regions achieved the set testing and positivity targets. That is out of just one campaign. But I must mention that our response has been characterized with so many campaigns addressing the different gaps to make sure that we run. So, first 95 requires testing. Second 95 is monitored by testing. And obviously the third 95 is monitored by testing. I thought I should bring the laboratory capacity in our country. Like Patrick mentioned, we are not doing so much of the lab, but it is also important to bring on board and mention that even the testing capacity has actually greatly improved. At first, like I mentioned, it was diagnosed in Rakai. We had isolated testing capacity. A few points were able to diagnose HIV. More so, even do the viral load and early infant diagnosis. Then later in the years, we had, I think in the early 90s, we had centralized referral for early infant diagnosis and HIV viral load. As of now, we have decentralized POC testing. We can do EID using POC. We can do viral load for priority populations like pregnant and breastfeeding mothers using our point of equipment. Of course, this comes in to supplement our conventional testing capacity. And on the side here is the different equipment that are available and the number of runs and the volumes that we're able to run. But in summary, we have equipment capacity to handle approximately 3 million tests a year, of course, which requires adequate and proficient human resource and optimization of resources to ensure efficiency. What has enabled Uganda to get where we are? One, strong political commitment. Like I mentioned, accountability in all the ministries and departments and agencies. There has to be HIV mainstreaming. But I must mention that our president is at the forefront. Like I mentioned, one of the things I said, presidential initiative, he is committed to eliminating HIV. That is very, very critical because we know that HIV is not an individual's fight. It is multi-sectoral and requires a lot of resources, requires a lot of engagement. So if the political environment does not commit to that, you may not be able to achieve your targets or your goals. Secondly, established quality HIV-related diagnostic services. That is very critical because we want to be sure that whoever has been mentioned to be HIV positive, they truly are HIV positive. And if we say somebody is HIV negative, they truly are HIV negative. We must establish quality HIV-related diagnostic services, not just for diagnosis, but also for monitoring treatment. Things like viral load, the liver function, all those ones are very critical for you to realize your achievements to the 95-95. Availability of an M&E framework. An M&E framework that does not only end at national level, but is broken down to a level that even when I'm in my health center, I am aware that I must report this, I must do this and report it, and this will contribute to the national targets. Availability of health management information tools, very critical. Not documented, not done. If these tools are not available, it is going to be very hard for someone to sit and recall, I saw client X, they had an adherence of this, maybe their viral load was this. We need to have the tools in place and people get trained on them, on how to accurately fill them, so that as because we know that from the lowest level, it is individual client, and we keep aggregating. So if information is missed right at the initial spot, it means even up to the top, we're actually going to have some missed information. Of course, we must print them and then have end user training on how to use those tools. Accountability fora. Without accountability, anybody would do anything as they wish. But these regional performance review meetings are very, very critical, because they not only hold the implementer, but even the commission is put to task to explain where they are using the resources and how they are using. The national program review, every program in this country has got to submit the accountability. So that pushes us to a mandate to make sure that we must be able to meet our targets. And of course, finally, AIDS fund, which we already mentioned that in every ministry, department, and agency, they have mainstream HIV-related activities, which of course comes with a small budget. So with those small resources, we are able to have funds that support HIV and AIDS implementation and then monitoring of our goals. What is our message finally to each one of you? Man, what's your stand on HIV testing? That's the first 95. These are some of the IEC materials that you find in many of our facilities, trying to address different. I just pulled out what's your stand on HIV testing? My wife tested, so I think I'm okay. No, your partner's HIV status is not yours. Please go and test. And it is to everyone here. Next, why give a chance? Why give HIV a chance to weaken my body? The day I tested HIV positive, I began taking my ARVs. Ask to be put on ARVs the day you get tested HIV positive. Finally, do you know your viral load? Testing for viral load helps you to know if your ARVs are working well and get support from a health worker. Go to the health center for viral load testing. These are IEC messages addressing the 395s. With that, thank you very much. Tapson, over to you.
Thank you very much, Madam Claire, for a wonderful presentation and insights. And I also wish you a happy birthday. So, as you heard, we have heard from Team Uganda about the importance of defining your results, not only the triple 95, because the journey is long, but also to have some indicators that should show you where you are. But we have also heard about their challenges, and those challenges are real, and I think they may be across all the countries, but also they have brought in an aspect of learning and adapting. You have the indicators, you have the goals, but you have challenges. How do you learn and improve your own performance? But we have also heard about the critical role the leadership plays. Without leadership, you can't have learning, because some of the aspects needs to be driven from them. You can't have funding. But also the eyes on the goal are going to be misfocused. But maybe for interest's sake, we also would like to ask the participants here to throw the questions in the questions and answer space so that they can be responded to by the Ministry of Health Uganda. But maybe from my side, as an interested party, the idea is, how do you have a lot of partners, it's multi-sectoral, but also you have the leadership. How do you engage them in terms of learning and adapting the senior leadership from the presidents to ensure that, because the learning cost is not about the activities not working, but it's also about this indicator is not moving, we also need resources. How do you manage to do that, and what are the forums that you use to do that? But also in terms of follow-ups, in terms of defining the indicators, do you reach a stage where you have defined the impact indicators as you have mentioned, but also you have defined the outcome indicators, but you have also defined the outcome indicators that are critical? What is the process like in terms of coming for them? especially working with the stakeholder. What is your experiences around that? Because that goes beyond the lab. It touches on other departments. What are your experiences that you would like to share with the members that are listening here? Thank you.
Thank you, Tapson. Like I mentioned, we are a big team on the call. So the question of how do we engage, I'd like to invite Charles Otai from the Uganda AIDS Commission to to give us the engagements. Because like I mentioned, we have different fora, but I'm sure Charles will be very good at we'll take. Charles, please, if you could unmute, and I hope you upgraded him. He's able to speak to the group.
Charles, over to you. Is he part of the hosts? Tim, you can be throwing questions so that they can be responded to. As we wait for Charles, you can tackle the process of coming with indicators, defining them because they are multi-sectoral, and what are your experiences in terms of challenges of coming up with those indicators that everyone should agree, and so that they focus on the goal and where you're going. As we wait for Charles.
Okay, thank you. Victor. Victor works with the METS, which is our monitoring and evaluation technical arm. So I'll invite him to speak to that. But like I had earlier mentioned, it is really multi-sectoral. Like you notice our NSP expires this year. So they have started engagements to develop these M&Es. But Victor, it's over to you.
Thank you, Claire, and thank you, Tapson. I think the question was how are we managing as a country to mobilize resources for the HIV response? If I'm to get Tapson's question, well,
yes, it was about you who have the leadership, the Prime Minister, the President, and you also have adaptive learning, which is learning and adapting. How do you use that how do you engage the leadership? This is very senior. How do you keep on ensuring, because they're also part of the learning process, how do you ensure they are part of the learning, but also they're able to allocate the support technically, but also in terms of funding? Thank you.
Thank you. The commission basically was set up coordinate ML sectoral response, and this brings on board different sectors into play. So in that coordination structure, we've got key sectors, including the finance ministry there. And then we also fall under the office of the presidency. I know the presidency is the fountain of honor. And then we are supervised by the minister directly in charge of the presidency. So we have a forum where we have meetings that are called by the office of the presidency at her level, and then they get briefs on what is happening as far as the response is concerned. And then we also have an opportunity of having meetings with the Minister of Finance, and we are able to utilize that forum to bring out financing issues for the response. I can give an example. We came up with the HIV mainstreaming guidelines, where we requested, where we asked for all government votes or all entities that receive government funding allocate 0.1% of their funds to the HIV response. Now, this would not be possible if we did not have the Minister of Finance on the same table. So the Minister of Finance will use their position to write an instruction in the budget call circular, instructing all entities to allocate 0.1% of their budgets to HIV response. So basically, we utilize that multi-sectoral forum to interact with all key players to create synergies to advance the the financing requirements. So right now we also have what we call a sustainability roadmap that we are trying to see how we can have the response being government-led in terms of funding beyond 2030, because we are seeing that funding by the partners is declining. And by 2030, we want to position ourselves as a country to lead the response. So this roadmap actually consists of all key players and the key ministries, including the Ministry of Health and the Ministry of Finance. But of course, above all is the political leadership of the presidency, who has led in all these efforts. Thank you.
Thank you very much, Charles. The other question on indicators.
You were asking about how do we develop the indicators? Victor,
yes,
please,
and
over
also,
to you.
yes.
Are we talking of indicators of the response? We have we have 5-year national strategic plans that we develop, and right now we are on our we're developing the 4th national strategic plan for HIV, which is aligned to the national development plan for the country. And we still, the development of this plan is again sectoral in nature. So we bring, we have our strategic plan is divided into 4 thematic areas: HIV prevention, care and treatment, social support, and then systems strengthening. So under prevention, we bring in, we've got technical working groups along those very lines. And then we bring on board key stakeholders from the different program areas to develop key indicators for the respective areas. So, for example, for prevention, is mainly led by the Ministry of Health, because the response is 90% public health, the same as care and treatment. But now when it comes to issues like social support, we bring in a ministry like the gender, which has the community element. We bring in the education sector. We bring in the cultural. So we bring in key stakeholders. And of course, within there, they have also got their experts in M&E. So when we design our programs from higher level, they are able to come up with indicators to measure those interventions according to the respective thematic areas and in the different program areas. So still again, it's a sectoral composition that comes together in technical working groups that are got from different sectors and key stakeholders to come up with the indicators to measure interventions in the respective program areas.
You get it. 1, involvement of multiple stakeholders, but also you must give it time. You must give it time to ensure that you don't leave any stone unturned and you don't leave out any relevant stakeholder. Thompson seems to be off for something. Over to you.
Yes, colleagues, thank you again, Team Uganda, and we are exactly at the top of the hour. Apologies for the glitch in connectivity from Thompson's side. We have still a few questions that have not been addressed. Because we have reached the top of the hour, we won't be able to deal with those questions. And like we have always done, we'll compile all these questions and make them available to the Ugandan team. And then once the responses are provided, this will form part of the materials that will get out there for your ongoing use. Thank you again for being part of this. And I'll just give Claire 1 minute to do your closing remarks. Claire, over to you.
Thank you, Francis, and thank you, team. The fight for HIV still goes on. We are close to 2030. Teams, the little that you do will bring the pandemic to the end. And thank you, SLM, for the opportunity. We hope about our response. We are welcome and we are happy to respond to anything and keep in touch. But otherwise, thank you so much and have a lovely evening or lovely morning wherever you are. Over to you, Francis.
Exciting, Claire, Patrick, is it Bijiro, Dr. Bijiro, my good friend, Anotai from Uganda AIDS Commission. So colleagues, we've come to the end of the session and we do wish you a very good afternoon or evening, depending on where you're joining us from. Be rest assured that materials will be shared with you as soon as they become available to us. Thank you.